Hi guys, I'm Andrea, and reflecting on my own personal experiences and groups that I identified as being othered in healthcare, I chose to talk about those who are homeless or who have low socioeconomic status. And I think that one bias that is identifiable for this group is that they are unhealthy or that they don't see their primary care doctor regularly, or any type of doctor regularly for that matter, and that their overall health in general is compromised. In a healthcare setting, I have definitely seen others who have this assumption. I used to work in a orthopedic clinic that's in a low income area, and we had a bunch of great patients, but there's definitely been times where surgeons may not want to speak with people if they think that they are not as clean as they were hoping, and the room may smell a little bit, and kind of like avoid the patient and the situation. I have heard the assumption that people with low socioeconomic status are just here to seek pain medication, that they don't see their doctor regularly, like I said before, and they only come in when they're in need of healthcare, or that maybe they use substances like drugs or alcohol, and that they're not as concerned about their health as someone of a higher socioeconomic status would be, just because of their overall appearance. I think that based on Cross Carry 2013, the article is based on a type 1 intuitive processing that we may have assumptions that affect the way the patient is assessed or diagnosed based on biases that are untrue. So if a provider assumes that a patient may be using substances or alcohol, they may assume that they may be impaired from those, when in reality they may have an actual physical or neurological problem going on. Or just thinking that they're here to seek pain medication and that's their overall goal, and not treating their actual symptoms that they have. And then also, it was stated in Cross Carry 2013 article that it can lead to type 1 processing can lead to poor judgment and errors from biases that have been taking over our thoughts as healthcare providers. So if we kind of set these assumptions in our minds that we may not dive into their history and their chart as much if we already assume that we know what's going on, or maybe there's a common issue with a certain group of people that they may just kind of go with and assume that that's the problem when it could be entirely something else. I thought a really good example was the story from the Cross Carry 2013 article about a patient who came in for abdominal pain and stated that they had constipation, yet the doctor gave them a laxative and said that they were, over describing their pain, that it wasn't actually as bad as they said that it was. And later the patient went to the emergency room with 1,200 cc's of fluid in their bladder and had quad equine syndrome, which was very serious, and luckily they were able to save the nerves before it caused any actual damage to the individual's bladder. So I think that kind of plays into just assuming that they're over exaggerating with their pain, like they are telling you what their symptoms are, and that everybody should be assessed and their symptoms taken seriously. I think another point from the readings was that Cunningham et al. 2018 stated that poverty is associated with a higher prevalence of physical and behavioral conditions, and they may come in more often with greater illness severity, especially if they don't see a primary care doctor, if they believe that they can't afford it, or they just kind of avoid healthcare settings. I think a lot of times people who may be homeless or things like that are seen with greater severity. And then also Madden, Kalhishman, and Zurowski, 2020, stated that outcomes are at least in part due to complex patients struggling to receive adequate care in complicated and expensive healthcare in the U.S., which largely favors and rewards patients with higher socioeconomic status and those who have better health and routinely take care of their health. And I think this plays a big part into patients possibly feeling othered and not coming in and seeking regular care. If somebody doesn't feel comfortable, they're not going to come in, or if they feel that they can't afford it or they're not taken seriously, they may not feel the need to come in because they feel like their problems aren't being answered or taken care of. And I don't think that people in this group experience equal care, kind of back to what I said before about the healthcare system largely favoring those of higher economic status and better health. I think that there could be a lot of improvement in people who are homeless or of a low socioeconomic status with treating them the same as we treat somebody who has a higher socioeconomic status or like really good health. And I think the effects that this can have on the individual in this group and the group as a whole is just not coming in for regular visits, developing a fear or an unhealthy relationship between healthcare providers and this group of individuals. Also, if they are at a shelter or any like big group housing, things like that, they may tell other people that they had a bad experience and that may deter them from coming in. If they feel judged or just feel that they're being treated differently. So I think that can kind of affect the group as a whole. And then they also might not feel safe if they feel like they're being judged. I mean, really anybody, if we're feeling like we're being judged, we may not feel safe or, not want to come back. And then I think healthcare providers really miss a chance to help individuals. They kind of decided this career path and that was their goal. So I think that's how it can impact healthcare providers, but also misdiagnosing, which can cause harm to a patient. And that's part of the oath as a healthcare provider that they take, and I guess we as nurses also take. So trying to keep the patient out of harm's way. And I think if I could do anything to change the healthcare system to better meet the needs of the population, potentially having like a free clinic day where group members from an organization go down and work with people at an outreach facility or a free clinic and just kind of meet people in a way where they feel comfortable, and maybe healthcare providers or the outsiders, and get to know them a little bit better and kind of build that personal relationship. Or even having like a teaching day with videos and individuals who come and speak and talk about ways that healthcare may make them feel, if they feel uncomfortable, why they feel uncomfortable, and kind of just giving them their story. I think a lot of healthcare providers are empathetic, especially when they put a name and a face to a situation. They may think of that in the future and kind of relate a personal story with another individual situation. And then maybe implementing the same process for every patient no matter what. So having guidelines that say, vitals assessment, certain history questions you ask everybody, and making sure that they're getting a really good background into the situation so no assumptions are made, and if they are, they could possibly be corrected. And yeah, asking those personal questions, and then helping individuals who are homeless or have low socioeconomic status. They may not have access to all the resources, so just making sure that those needs are met, knowing the resources in the area, maybe having a teaching day on that, just so as a provider you can recommend these sources. Social work is another great resource, so making sure that if they need help with any social work areas, and also just remembering that there are a lot of people who are either homeless or low socioeconomic status that may see their doctor all the time. I thought that I was surprised by how many people regularly see their doctor at the ECLA Outreach Center that we did for the Community Nursing 6000 class. So I think just trying not to make those assumptions is really helpful in providing better care and the correct diagnosis.